Good day. My name is Klaus von Pressentin. I'm from the Division of Family Medicine, and it's my honor to represent this group of very like-minded and passionate colleagues. Our goal really is to focus on how best to prepare clinical leaders for their future role. And we have going to describe this approach of incorporating a coaching style to deliver a leadership and governance module, specifically aiming at postgraduate students in family medicine. Our thinking is that this approach might be useful for the TLC community and the broader UCT community, and even beyond. And we would like to encourage you to really engage with this talk and also already imagine ways of connecting and collaborating. Because as you will see from this talk, the idea is really for us to showcase what we've done so far, and maybe also present some of our issues of current challenges that we grapple with. And we would like to invite you to maybe also engage on how best to enhance this module and similar activities. This might be a way also of looking at what's happening elsewhere within the UCT community of developing leaders, both in health professions, in clinical fields and other contexts. The question of leadership, especially in the health system, becomes especially important if you think about the state of primary care. And it's important to distinguish the primary health care from primary care. So primary care is really the setting where patients and providers interact with either facility spaces or in community spaces. And it's typically the area where members of the community seek help, and we describe it as first contact care. This care is typically provided in the public sector in teams, but in both private and public sector, more and more there's a realization that a team-based approach delivers high-quality, comprehensive care that meets all the primary healthcare domains of prevention, promotion, curative service, and palliative care. The Lancet Commission described the dilemma for educators in the 21st century, especially in the health professions, about how best to equip health workers to meet the growing and evolving needs of communities. And as you can see from this very interesting slide, there is this constant iteration of the education system and the health system focusing itself around the needs of a population. This concept of social justice or social accountability is really seen as the centerpiece of a way of describing how best can we look at the evolving health system and health service landscape and see how our graduates can be trained for purpose to meet these needs. This is a very complex system, and as in terms of complexity theory and complex adaptive systems, the human element is especially key, and that is why our focus is on the need, among others, as a multi-pronged approach to capacitate health workers as leaders. And when we think about leadership, we really think about the comprehensive view that everyone is a leader in their sphere of influence. And this resonates with this report published in the UK in July of 2022 that speaks about the global perspective of health workers as agents of change and also curators of knowledge. It describes several global drivers of change, most of which we are quite familiar with, especially in the recent pandemic, where we have realized again that there are external events that will challenge the health of communities and society at large in different ways. We also understand that there are several crises in the health system, and especially among the health workforce, the people that provide the care, in terms of burnout, attrition, brain drain, and other factors that affect how teams function, and especially as they try to rise to meet the challenges with this evolving space. So fortunately, the authors of this report have also identified a few radical possibilities to put a positive spin on it. One of the things is around teams being self-organizing, and it talks about the whole leadership fellowship concept, and also the need to redesign and integrate primary and community care, and to underpin and support that from a training perspective. We need to also look at how we reform our education system, and especially from a transformative perspective, which really talks about leadership and the need for partnerships, for us to really partner at the micro level, but also at the macro level to meet these challenges. In primary care teams, the doctors are often seen as leaders, but I want to also state this caveat that doctors are only one component of the primary care team, and the leadership really is about the collective and aligned with the needs of the community, and at the micro level, the needs of the patient or the person seeking help. And it can be at different stages of the patient's journey. Several members of the team can alternate the leadership around the care for a particular patient. But in terms of the structuring and organization of health services, typically primary care doctors are looked upon to provide a leadership role. And the emerging and role of primary care doctors have been described in various settings, including some of the BRICS countries in China, India, and Brazil, and South Africa in the report cited, where we appreciate that a doctor in primary care teams should not only just be competent clinicians, but they should have other qualities and skills that need to be developed and harnessed and nurtured, such as critical thinking, building capability and capacity within a team, collaborating within the team, but also across levels of care and with community stakeholders, and even advocate for the health needs of their community. But importantly, they need to be seen as change agents, which really speaks to the need for the developing and training leadership. And just to orientate the audience, I just want to describe the district health system of South Africa, typically how the system is organized in the public sector, but also importantly, as we imagine this future more integrated health system under the National Health Insurance towards universal health coverage, we need to be cognizant that there is a need for everyone to be oriented towards a district health system, which is really a World Health Organization concept. It's not something unique to South Africa. It's a way about structuring the health services between the facility-based in green and community-based components in purple. The district health system also involves not only the community-based space where primary care teams typically operate, but also the level 1 or district hospital setting where the generalist services of inpatient nature, including emergency care, palliative care, and operative care, is provided in teams. And this is in South Africa where we imagine family physicians as expert generalists taking the lead, but also situating the need for primary care teams to work across the primary care or district health system, facility and community spaces. You will see that specialized services on either side, especially around psychiatry, rehabilitation, and dental services, are also incorporated across the continuum of the health system. And that the other role of district hospitals is especially as important function to where that interface between the community or district health services are coordinated with the more specialized services at the regional and tertiary training hospitals. The South African primary care workforce is in terms of its training, is described as in this image. As you will see to the left, the medical students are trained in an MBCHB program for 6 years, following which they have 2 years of compulsory internship, followed by compulsory community service year. These steps in green are compulsory in order to be registered with the Health Professions Council as a medical practitioner, competent and trained to meet the health needs, typically in the district health system. We at UCT, a Faculty of Health Sciences, envision our graduates to be competent generalists that can function well within teams in a district health system. Following graduation, there are several additional ways to develop more trained members of the primary care workforce through postgraduate training options at diploma level as well as master's level. The master's level is typically the specialist in training or registrar program, such as the one offered at the University of Cape Town's Division of Family Medicine. And following the 4-year training period, the graduate is then employed either in the public or private sector as a medical specialist in family medicine or a family physician. It's important to note also that the general practitioner or medical officer are graduates from the MBCHP program following their community service here who may or may not have additional training in primary care. The story of family medicine in South Africa, as in typically in the wider sub-Saharan African region, is typically one of emerging discipline. One can think of other specialist disciplines that are more established and more familiar, maybe also to the general public. So it's important for this audience also just to understand where family medicine fits in. Family medicine only became a specialty or recognized by the Health Professional Council as a specialty in 2007. That's 15 years ago. And the first graduates from the newly reorganized training programs at postgraduate level entered the district health system around 2011. South Africa has also committed itself at the policy level to primary health care in line with other countries across the globe. And in the National Development Plan, the important role of family physician is recognized, especially in terms of clinical governance, which talks or speaks to health service strengthening, ensuring that teams are trained well and able to deliver and perform in unison to meet the health needs of their particular population or community that they are serving. And that is the hope of this clinical governance, is that it will lead to the quality improvement that we would like to see. The South African Academy of Family Physicians has put forward 2 national position papers over the past decade or so to the National Department of Health as well as provincial departments of health to provide consensus on how these graduates ideally should be appointed and deployed within a health system to meet these goals. We have done some research as part of my PhD at a national scale in 2015 and 16, where we started to evaluate the contribution of these graduates from the new training program, the Masters in Medicine, with the idea of trying to understand how are they being received in the health system and are they already able to influence the district health system. One may argue that it is early days, which is true, and that is why we look at it through different lenses, both quantitative and qualitative. The qualitative lens involved district manager interviews across 7 South African provinces. Because we focused on district managers, we appreciated that they have almost like this bird's eye macro perspective of what's happening in the district that's under their governance. And especially as district managers also have an important role to play to employ and also manage this new cadre of medical specialists. The district managers uncovered a recurring theme. From the start, it was clear that there was this perception or understanding that family physicians, in a way, need to be able to lead, but also be quite firm in terms of their own understanding and their ability to influence their sphere of influence or their context. The district managers typically were expecting that they needed to have these roles of improving, expanding, and developing the services. Some district managers were also clear that they have witnessed some examples of family physicians who were at the mercy of the system, typically those that were perceived to lack necessary leadership skills and were not able to integrate and influence their teams. On the contrasting aspect, and encouragingly, family physicians with leadership qualities who showed resilience were appreciated for their ability to be change agents and to shape their context. One also needs to understand that the district health system environment is exceedingly complex, with a number of factors in play, not only the human nature, but also the challenges typical of a generalist environment where one has issues of resources as well as different diagnoses yet to be defined, and also understanding that the different role players are involved in ensuring a comprehensive package of care. So, it was agreed by district managers from these interviews that these newly qualified medical specialists in family medicine need to gradually embrace their roles. We'll talk about the 6 roles in the following slide, but important to understand that it speaks to their need to gain experience and grow in maturity. And how does that happen? So the district managers also highlighted some possible enabling factors, such as a supportive team, the need to role clarify who does what in the team, and to also appreciate the need for management, especially in administration and governance sectors, to support these new graduates within their team. There's even an appreciation for mentoring from other more experienced or senior family physicians and other related disciplines for those specialists to also influence and support these newly qualified family physicians. So important to also state that maybe as opposed to other medical specialties who are typically based within a more consolidated, less dispersed model in one health facility, family physicians typically work as a solo family physician in maybe a single or in pairs within a certain sub-district of a primary care facility within a district health services. So typically they are fairly new or alone in their primary care team, and there is not the typical junior and senior consultant roles one sees in more established disciplines in the secondary and tertiary hospital environment. All of these factors necessitated the role of educators in understanding how can we better prepare family physicians for this complex environment and this very complex role. So at the national level, through the South African Academy of Family Physicians, we had this process in 2015 and 16 where we engaged with several stakeholders to come up with the learning outcomes and competencies required of the family physician. This was then also incorporated in the latest version of the learning outcomes at the national level. And these are the 6 roles I alluded to earlier, ranging from a care provider and a consultant to the team, as well as capacity builder within a team and trainers of students, as well as the role for leadership and championing of community-oriented primary care. One can organize these 6 roles conceptually into these 3 main spheres of influence. And we want to specifically focus on the role of leadership, although one understands that leadership really is involved across the spectrum of all these influences. These updated programmatic learning outcomes across the 5 unit standards need to be incorporated during the 4 years of registrar training. Unit Standard 1, as depicted in a table here, describes the capabilities required for the leadership role specifically. Unit Standard 1, as you can see, talks about the family physician or registrar being able to manage themselves, their team, and the practice. So almost this I, we, it model of leadership development. There is then also needs to be trained sufficiently in an equal manner across the 9 training programs nationally, of which University of Cape Town is one. And at the end of the 4 years, this needs to be assessed at the exit level through the National College exam. We are now also looking at incorporating entrustable professional activities, EPAs, in terms of programmatic assessment, and this will be linked to a revised and updated portfolio of learning. Following the national picture, I want to zoom into our experience here at UCT. And this will lead us into the development of this leadership and governance module we've been talking to. As you can see, the Division of Family Medicine, since the end of 2021, is now situated within the Department of Family, Community and Emergency Care. And our desire as a new department, of which family medicine, palliative care, emergency medicine, sports and exercise medicine, as well as the primary healthcare directorate is part, is to build inclusive communities of care together. And this also speaks to the community within the UCT environment. So again, the call to engage with the talk and also proactively think of how you wish to be part of our ongoing development. At the end of 2021, we reflected on the current module at the time, which was offered in only 7 sessions over a relatively short period of 3 to 4 months. And that has been a way it has been offered over the past few years, except for the COVID period. We engaged with both facilitators and students who were part of the module and realized there were several pros in the model which we want to preserve, but there were some challenges that need to be addressed and to really make the module more meaningful. So we were grateful to the content and presenters, but we realized that the time in these sessions, as you can imagine, 7 sessions is quite short, and which didn't allow for sufficient opportunities for reflection of the learning, on the learning for practice. And this speaks to the paper that was published in 2021, which also recognized that there's the same dilemma that we experience with our module is that there's a lot of content on the technical or the knowledge component, but not enough attention to the more important, as important leadership domains of self-awareness, emotional intelligence, and a bigger organizational understanding. This paper also made this call to address the competency-centric medical education culture and alluded to the need to prioritize coaching, discussion, and reflection as methods of delivery. Important to note also the difference between coaching and mentoring, which I'm sure is something we often grapple with, as well as how that differs from training. So one of my colleagues, the co-convener of the module, Angela Dessar, has been engaging with Paddy Pampalis at the Leadership Coaching Institute, and they have been looking at ways of capacitating all kinds of professionals as leaders, using an integrated coaching approach. So Angela and Paddy have been chatting with me, and we've been thinking about ways to enhance the module together with Dr. Tasleem Ras, our convener of the overall family medicine postgraduate program. And we realized that we needed to incorporate an element of coaching. So this then led, following this feedback with several stakeholders, to a revised module, which we implemented this year. We wanted to expand opportunities for facilitated learning and reflection within the group. We wanted to incorporate group coaching as opposed to individual coaching, and also look at spreading the teaching content across more sessions. So this allows us for more sessions with less didactic content and more opportunities for reflection facilitated by a coach within the group setting. We blueprinted the new national programmatic outcomes across the 12 sessions, and we made 8 of the 12 sessions content sessions, which I will talk to in about a moment, but also have 4 sessions dedicated on leadership development. We use the Enneagram as a way to help participants in the module to uncover their self-awareness as in terms of their own leadership style and profile. And it's important that we also made particular attention to the group coaching style, especially for the content sessions, to in a way help the students to translate their new learning into the context of practice. So making sure that what happens in the sessions is also in a way reimagined or repackaged in the learner's own mind about how to apply this in their current and future practice. This is just a brief overview of the planner of the module, which shows in the second last column on the right the unit standards. That's the blueprinting. The first 2 and the final 2 sessions are the dedicated leadership sessions, and the central 8 sessions are the content sessions I alluded to. And we have several presenters ranging from healthcare managers, public health specialists, practicing senior family physicians with years of experience, as well as a private sector, a general practitioner leader, all involved in the module faculty to provide the content of the sessions. The 8 content sessions are balanced between the first half, that is the delivery of the content, facilitated by one of these experts, one or more of these experts, and then followed by a closed session where there's the group reflection. Why I'm saying closed is that it's important, especially from a group coaching perspective, to create this community of practice and as well as a safe space, this container for reflection and learning together. And this then was also then done with certain principles in mind. So typically external guests are not invited for this more closed session. And as you can see there, we use this second session with some guiding questions in a facilitated coaching style to situate the new learning and also help the attendees to reflect on their current practice and imagine how they will use this information in their setting. And as we've alluded to in the slide on coaching versus mentoring, the whole principle is that the individuals and the group has the expertise and the knowledge from their own experience, typically with adult learning theory, that this is not new learning, that they are not a blank canvas, but they bring their own experiences into the sessions, and they are able to make sense and meaning of the new content presented by the expert, and as a group digest this information and reflect on how they will apply this in their setting. And then the group will typically learn from each other as well as come up with possible solutions on meeting gaps that are encountered. Excitingly, we were able to include Siyabonga Kubeka this year as a third-year medical student in our initial evaluation process of this revised module. In the third year of the medical undergraduate program, medical students have to complete a 4-week special study module, or SSM, and we put this question to Siyabonga, and he actually volunteered to join this SSM, or special study module, on forming an initial scoping review about the role of coaching in leadership development. And it was quite interesting reading his report to see how what was described in the literature, mainly from the high income settings, although there was a scoping review also aimed at low and middle income settings, about the different formats and modes of delivering these types of leadership development sessions aimed at clinician leaders. So the articles ranging from scoping systematic reviews to lower levels of evidence looked at coaching, mentoring, and other didactic teaching methods. It came very clear from this report that coaching in itself offers a unique opportunity for developing of autonomy or self-development, and helps prepare the clinician leaders for an uncertain and changing future. And this resonates with the initial slides about preparing health leaders for this evolving space we find ourselves in. As typically with all research, as we start unpacking these answers, we realize that not enough research or evidence is available to guide us, and we have identified follow-up questions that we hope that, if interested, you might join us in terms of collaboration and co-creation to meet these gaps. Interestingly, there was limited information also on the role of group coaching as opposed to individual coaching in leadership development. Informal feedback from the group at the end of September this year showed us some encouraging feedback. And I need to state also at this stage that the group consisted of a mix of group members. Typically, the module is offered to family medicine registrars in their third year of specialist training. But as the 2022 cohort consisted of only 2 registrars, we were looking with the guidance of the group coach at ways to enlarge the group for an area of about 6 to 8 participants. And this led us to also including some postgraduate students at diploma level who are practicing medical officers within a district health setting, as well as recently qualified family physicians to join the group. And this is what the group had to say. They were actually quite appreciative of the size as well as the mix, having people that are less experienced and more experienced, appreciating, of course, that years of training, of years of practice does not necessarily reflect on the level of leadership development. And it was really encouraging to learn the insights from this diverse group. The group also resonated with the idea that there is a need to also incorporate leadership at an earlier level, at the undergraduate level, as often this gap or need is only unmasked upon graduation. And speaking from practicing clinicians in a district health system, we were reminded again about the need to build wellness and resilience and to prevent burnout, to help clinicians in primary care teams to make meaning and to build connections. And this links to the concept of self-awareness and the leadership of self, the self-management. It was very encouraging to see how one of the participants has already used this group coaching and reflection style in their own context with their own primary care team. And this then also led us to think that maybe there's already the beginnings of a community of practice that is being developed. And this might be an opportunity also from a research, but also from an educational perspective, to think about how can we ensure the continuation of this support. Is it for a final period, or if interested, is there a way to extend this connection both formally and informally? So finally, I want to end off with some of our insights and ideas that we have uncovered in our journey of developing this revised module, and want to really reflect on what does it mean for our current graduates, but also think about what could it mean for our existing community of family physicians working in a system, as well as educational leadership programs. What can we do across different disciplines within different faculties to work together? I mean, clearly there was some benefit to this module, to this cohort that we have witnessed. But we want to incorporate both the experience with the evidence and the literature to ensure that we build on this educational innovation in a sustainable manner, but also remain open and curious to this journey of ensuring its relevance to the changing nature of a health system and the needs of our graduates. So one of the key things we realized is that growing as a leader in a very complex environment speaks to the role of identity formation as a professional. And this really is a journey with no necessary endpoint, but ideally one will have certain chapters of one career or life where one goes through periods of growth and discovery. The module should be situated within a bigger program. Clearly, one module is not enough to really translate what has happened in a university environment and to translate that into the clinical context. So we need to think also about how can we incorporate it into workplace-based learning and as well as assessment. So we, as alluded to earlier, this portfolio of learning could help capture this growth beyond the module. The timing of the module within a 4-year program also might need review, because originally this module was conceptualized when one was thinking about capacitating senior registrars in their program. But we realized from the mixed cohort from this current year is that there is a need to also consider how can we incorporate some of the group coaching and reflection sessions and principles, perhaps at a diploma level, undergraduate level, and across the continuum of the MEd program. We realized that the needs of individuals and contexts are really quite diverse. So we need to consider training in a very tailored manner and to be adaptive in our training and coaching and leadership and educational styles. So thinking about maybe the formal curriculum versus other opportunities to develop would be increasingly relevant. And then finally, one needs to think about how can one support graduates that emerge from this module and the program. One example could be the Next 5 initiative from the South African Academy of Family Physicians that supports newly qualified family physicians within their first 5 years to enhance their ability to grow as resilient leaders, able to influence their sphere of influence. It's important to think about how do we change from the role of a registrar into a newly qualified medical specialist, and also to think that often we are maybe trained in a certain context but end up practicing in quite a different one. So how can one think of the generic attributes and skills and incorporate that in one's lifelong learning and journey? Finally, as mentioned earlier, this is an open call for collaboration and co-creation. It might be that some of the principles of the design and execution of this module might resonate with your own understanding, might pique your interest. So we would like to perform a combined or collaborative educational research across different programs and disciplines and even faculties. I would really like to thank and acknowledge the team at UCT, including the postgraduate committee and the students that have been involved in both the delivery as well as review of this module. I look forward to learning more from you and enjoying the 2022 Teaching Learning Conference. Thank you.